Oh Lord, be with us and give us grace to understand everything we are going to study. In Jesus' name we pray. Amen. I'm done with this question. I think so. Um, I'm done with this question. Dear, dear, we put him lemon because no vex. My throat is cracked. Sorry. Okay. Today I was having a discussion. I was discussing with one of our missionaries. I was discussing the RAS map kindness pathway. It made a lot of sense. Kai. Sometimes understanding the pathways is very.
Which was the person's area of study?
Don't mind me. But is architect.
Why not discussing?
So I wanted to record a video or something, so I called him to join me so that I can create the interaction transcription session of the video.
You're
Okay.
very funny boy.
Yes, a very funny one.
For the man.
Oh my me. He was actually he was free now. I don't know if he was free, he was there available. So he joined me and he kind of got some little explanation here. I understand little about leukemias and all those things. It was on him part. Now let's look at this review. Answer this
I
question.
wish we can finish this thing today. This
Yes,
is this question.
yes. I don't know how long you have. We can finish it. So let's start.
You will also sound the fast a little.
Mm.
Okay. I can't see the question very well.
Let me share my screen again.
The follow regarding my fibroblastoma are true except
I will say B.
yeah. Sorry, I still did not see it.
Oh, shit.
The network, I don't know.
Can you see it now?
I'm trying. I'm coming. I want to also adjust it on my hands.
Should I make it larger?
No, I'm adjusting it at my hands. Okay. Ah, you know,
Let me make it
it's
larger.
blood. It's blunt.
It's blood.
Blood, rather. Mm.
Um, Let me see if it's going to be sharper now. How about now?
One, but not on the left.
Let me make it larger. What about, can you see it now?
Okay, let me read on my phone.
Can you see it now?
Let me read it. Yeah, I can see it on my phone.
Okay.
Not yet on the laptop, but let me read the phone first. Later, the laptop. All the following regarding myeloblastima are true, except the clinical precision is characteristics is characterized by mobile web training.
Thank you.
My favorite this is the most quintessential of the maelstrom people. The chairman compose the boundaries of the program. I'll say B.
Okay, let's see. Oh, okay, okay, okay. Oh. Oh my God. I when I clicked
What's
the
the answer?
I was manipulating it wrong. I was trying to manipulate it when I mistakenly clicked the wrong answer. I knew the answer was B. The answer is B, and when I clicked the wrong thing. Oh,
You
no,
can't change it.
change it. I mean, this is failing question I know already. You understand? Like
Hmm.
failing a question and then I was, oh God. Okay. It occurs in older men and post-menopausal women. Everything is correct. So let's quickly review it. And you still remember myofibroblastoma? Let me show you
Hmm?
myofibroblastoma. Do you still remember myofibroblastoma?
Hmm. The spindle cells then interfere with collagen. Fibroblast interspersed by collagen fibers.
Yes. If you look at it here, well circumscribed lesion, well circumscribed lesion, they may have pushing borders. You can see collagen, spindle shape, spindle cells, shape cells with short fascicles separated by eosinophilic collagen. Nuclei are round to oval, dispersed chromatin. Sometimes they even have mast cells in it.
Mast
Uh,
cell.
can be seen in solitary fibrous tumors as well. I've actually seen a real lesion before. So,
Mhm.
what is the IHC you do for a myofibroblastoma? What IHC will you do for myofibroblastoma?
Desmin, small
Mhm.
muscles, and I did CD34 positive.
CD34 is the main IHC. So that was another important. All you need is to do CD34 ERPR. Which other tumor resembles it that consists of expansion of fibroblasts, myofibroblasts, both of them expanding? What tumor is that?
Mm,
Nodular fasciitis, remember.
okay.
Nodular fasciitis, it will be CD34 negative. And what else? I think it will be um it's usually everything negative. I still remember. So and they have tissue culture pattern. This is myofibroblastoma lipomatous pattern, chondrolipoma with cartilage in it.
Which
This
one is this?
this is still myofibroblastoma.
This is background look fatty, right?
Yeah, there are some that have fatty pattern, a lot of fat in it. All these tumors they have their different subtypes. This is epithelial
Okay.
pattern. This is epithelial pattern. The cells look roundish. I mean, let me see, the nuclei are more epithelioid, thin cytoplasm, and they have a lot of collagen intermixed with it. This is the epithelioid pattern, oval, round nuclei, interspersed collagen. This is invasive lobular carcinoma, so it sometimes resemble if it's very muscle, it sometimes resemble myofibroblastoma, but it's not going to have this round pushy bottom.
And the cell will not be this atypical.
Yeah, yes. Even the cells of myofibroblastoma are not really typical like that. Now, low grade
This
invasive,
one is atypical. Like this one is a cancer.
yeah, prominent
Can,
nucleoli.
can you say they are pleomorphic, you know?
Yeah, right. And not only that, it will be cytokeratin positive. You know that myofibroblastoma is a cytokeratin, is a chimal tumor. So
Yeah.
keratin negative. You understand? So this estrogen receptor ER positive for myelofibroblastoma, desmin positive, like you said. CD34 is the main hallmark of this disease. BCL2 positive, actin also positive, keratin negative. Why is it keratin negative?
It's not epithelia, it's
Yeah.
mesenchymal.
Okay. This is PASH. PASH may resemble it at times. I mean,
Pseudoadenomatostroma hyperplasia.
PASH has ill-defined border, but we surround epithelial elements and epithelial components. This leiomyoma of nipple. This is solitary fibrous tumor. I've not even done soft tissue to look at solitary fibrous tumor very well. Usually start 6 positive. This fibromatosis. Fibromatosis. What is the hallmark of fibromatosis?
They have a long sweeping spindle cell fascicle.
What else?
Uh,
They have what else? They have what? Uru. Don't take any time, not give you. Lymphoid aggregates at their periphery, remember?
okay.
This spindle cell carcinoma. Come here. Dermatofibrosarcoma protuberans, PASH. And then in terms of immunohistochemistry, this is lipomatous pattern for myofibroblastoma that has a lot of fat cells. Myoma of the nipple, fibromatosis. You know, I'm not gonna have oh my God. Fibroblastoma. The myoma of nipple is going to be closer to the nipple. This solitary fibrous tumor. Solitary fibrous tumor have stagnant cells, stagnant vessels. This myofibroblastoma border. Myofibroblastoma border. So solitary fibrous tumor came up so many times because if you mix it a lot, I don't know why. A lot of collagen, Solitary fibrous tumor will start 6 positive. Another thing that myofibroblastoma has androgen receptor. Remember,
mhm.
androgen receptor
and
positive.
and also ER too, right?
Yes, androgen receptor positive. It's sarcoma, very pleomorphic. This I think it should be cytology. I don't know. So let me just summarize some genes and other things here. Like you said, we are trying to be very fast. Then I also want to differentiate it from for the differential diagnosis cases. So like the regular fasciitis, okay, so let's look at sorry. So myofibroblastoma is a benign spindle neoplasm arising from myofibroblasts in the breast. We have myofibroblasts, we have fibroblasts. If it arises from fibroblasts, we call it what?
Hmm?
The breast, we have fibroblasts, we have myofibroblasts. And so
Fibromatosis.
chromatosis is the one that arises from fibroblasts. If it arises from myofibroblasts, what do we call it? Myofibroblastoma, right?
Okay.
What if it arises from both?
From both.
Nodular fasciitis can arise from both. Okay.
Okay, nuclear fasciitis. So we have fibromatosis, which is fibroblast.
Yeah,
Myofibroblastoma, which is myofibroblast, and then
yeah,
nodular fasciitis from the.
yeah. Nodular fasciitis will be painful, rapidly expanding, tissue culture, and negative for everything instead of hexing. So why fibroblasts? Now, spindle cells are very long, slender under the microscope. My fibroblasts, they look like muscle-like fibers, mammary stroma structure. They don't need this. Pathogenesis, they are associated with deletions in 13, 14, 13q14 and 16q. The gene, retinoblastoma, there's lots of retinoblastoma, it's associated with loss of RB1. Epidemiology is a very rare tumor. I've seen one before. It affects both sexes equally with more male, slightly male predominance. Can you imagine? The one I saw was female anyway. It's unusual for breast tumors to affect male.
Myofibroblast, yeah, is a male, one of the male tumor now.
Hmm. Wow. And people with between 50 to 75 years of age is a painless tumor, slow growing, circumscribed, and mobile mass. A painless, slow growing, well circumscribed and mobile can be detected incidentally on mammography. Imaging findings. Mammography shows a solid circumscribed unregulated mass, like we have here. Ultrasound, hyperechoic circumscribed lesion, MRI, don't need that. Fine rotary lesion on gross pathology wall, nodular appearance, can be up to 10 cm, not encapsulated. Microscopy, uniform spindle cells arranged in intersecting fascicles, interspersed by highly collagen. Collagen interspersing is what helps me a lot. Mast cells can be present. Circumscribed tumor with epithelioid kind of spindle cells interspersed with collagen. That's myofibroblastoma. They lack nucleate sepia. The different patterns, lipomatous myofibroblastoma, epithelioid type, myxoid type, palisading type, fibrous type, infiltrative variant. We don't need all that. What I did now is the RHC. For the IHC, CD34 positive in 90 to 95% is ER, PR, and AR positive. Is Desmin positive. HCal, Desmond is focal. RB loss, S100 negative, and STAT6 negative. Let's look at IHCs to differentiate. We're almost done. Fibromatosis, myofibroblastoma, and nodular fasciitis. Yes, remember we said in fibromatosis, the hallmark is nuclear beta catenin positivity. You remember?
Okay.
It has nuclear beta, well, nuclear, oh God, sorry, fibromatosis. It's speculated, not it's speculated, not it's speculated. Unlike myofibroblastoma that is well circumscribed. It is speculated borders, infiltrating borders, spindle cells. No collagen it has. Thick collagen bundles can be seen. You see the lymphoid aggregates at the edges for fibromatosis. Can have perineural invasions. It can invade muscles. Look at it now. The nice nuclear beta-catenin staining. That's a hallmark for it. And it is negative for CD34. CD34 is normally positive in myofibroblastoma. It's desmin positive. Of course, cytokeratin negative. These are mesenchymal tumors. Okay. And remember, fibromatosis is associated with what? What syndrome? You remember the syndromes?
Fibromatosis. Is it Carney syndrome?
You say Gardner syndrome, right?
Okay, God now.
Yeah, we have Gardner and Tocqueville, which are parts of the familiar Andromatous polyposis coli. We even try to trace the pathway then. But trust me, in pathology, we always forget. Gardner syndrome is familial adenomatous polyposis and what? Fibromatosis, right?
Okay, okay, okay.
That involves and this tumor involves the CTNNB1 pathway. Remember that
Okay, okay, okay.
nuclear beta catenin. Um,
Fibromatosis and IKP. Okay, oh.
yeah, so we also now, so when we start watching the videos, this is nodular fasciitis. When we start watching the video, our tissue culture pattern, patternless pattern. When we start watching the videos, it's going to help us a lot to revisit and remind us of these things. And then okay, this tumor can be CD34 positive and all that. Okay, yeah, we are done. Let me just rush through it. Good. So we said nuclear beta catenin is the main thing. Nodular fasciitis, the hallmark is clinical diagnosis, rapidly growing with mitosis, inflammatory background, and SMA positive. Yes, it's SMA positive, but CD34 negative and beta catenin negative. CD34 is for myofibroblastoma, beta catenin is for fibromatosis, and then SMA, well, nodular fasciitis. It has USP6 gene rearrangement. USP6 is found in what kind of bone tumor? Do you remember?
Anular bone cyst.
Aneurysmal bone cyst. Wow, you're so good, man. Very good. Okay, very good. So that's it for this. So you will you will um you will explain these points and then we'll answer questions and we are done with this question. I've done the expert part version. You do this one. Okay, can I start reviewing it? Can you see the screen at all? Is it too tiny?
Uh, I don't know. Maybe it's internet. I don't even know. Because I can't see it on my lap. On my phone, it's not very clear on my phone. On laptop, I cannot even see it at all. So I'm
Can
using my phone.
you see it now? Can you see it now?
Mm, manage. Oh, is there? Which one do you want me to see? Teaching points, right?
I'm trying to explain it. The whole of this area, I'll be scrolling. When you want me to scroll up, I'll scroll up.
I can't read it though.
Can you log out and log in again and see if it's going to be better?
Okay, let me try.
Mhm. Sure.
Teaching points on manufactured.
Press.
Still can't read. Hello, Jonah.
Yeah, can you see it now?
I can only see some. I can't see everything. Some of it look blood.
Why is it blood? Like, let me try to share my screen. Let me see one more time.
Yeah, it's clear.
Oh, oh, I was trying to share my. After the thing became clear. Oh, how is it now? It's blood again, right? Hello.
Yeah, yeah. It's clear now.
Very good. Hey, can start, sir.
So differential diagnosis and CD test for immune activity. Uh, Different types of myofibrils those include some mesenchymal and soft tissue lesions and neoplasm and fibromatosis. In contrast to myofibroblastoma is characterized by infiltrative growth and is negative for CD34. Like, okay, all right. So fibromatosis is characterized by infiltrative growth and negative for CD34. Myofibroblastoma is positive for CD34 and
So
is
what,
circumscribed.
so
Circumscribed.
what is positive in fibromatosis?
CD34.
No, I say fibromatosis.
Okay, so that one is beta catenin positive.
Yes.
Nuclear beta catenin.
Very good. Let's continue.
Myofibroblastoma is the nice movie cell. Okay, we talk about it. Bland, okay, infiltrative. All right. Then key differential diagnosis. Myofibroblastoma, okay, CD34. Desmin is positive, often positive myofibroblastoma, variable in fibromatosis. Clinical presentation, locally aggressive in fibromatosis, benign in myofibroblastoma. Isogenetic link with spindle cell lipoma. Similar cytogenetic profile, cytogenesis profile is shared with spindle cell lipoma. That's myofibroblastima share similar cytogenetic profile. Loss of 13q14.
Remember, there were two things we saw that we didn't even pay attention to here. Pardon me. If you look at here, we saw the cytogenetics where there was lots of retinoblastoma gene located at 13q. So there were deletions in 13q, 14, and 16q. Okay, continue.
Involving RB1 and FSO1 gene. FSO1 genes. Fox, sorry. Not morphological both tumors feature bland spindle cells, ropey collagen, and subtle admixture with mature adipocyte. Immunohistochemically, the both possess CD34 desmin hormone receptor. The shared features support the hypothesis of a common isogenetic origin, likely from CD34 positive mesenchymal stem cells in subcutaneous or mammary tumor.
Do you know
Then
spindle
we
cell
go
very well?
any
Do you know spindle cell lipoma?
uh,
Can we look at it quickly?
where is it for? I can't remember the paper.
That's that's pathology for you.
Lots of 13 to 14.
Hmm?
RB1 is also
Spindle cell lipoma. Which one should we look at now? Is it head and neck or pleomorphic? Let's look at spindle cell lipoma. Let me see. It's not much. Let's use this.
okay.
Spindle
Okay.
cell
I
lipoma.
think we have already discussed other points, other manufacturers.
Because
Yeah, to the
I
cover.
can't hear you well. Have you
I
discussed
said,
it before?
I said we have discussed other points under myofibroblastoma, epidemiology, this demographic.
Yeah, but what I'm trying to say is that they want us to review spindle cell lipoma.
Yeah, we can quickly do that.
Okay, good. I'm coming. So we can quickly look at spindle cell lipoma because I think
Mm,
we don't know where we're going to come across it. So, and it's a very great mimicker of this disease, according to
yeah. Or
so
what?
obvious myofibroblastoma.
Yes, yes.
Mix
They
it
are
in.
both, they have the same cytogenetic quality or criteria. Lots of 13q14.
Which is retinoblastoma gene is included in chromosome 13, right? So
Mm.
that spindle cell lipoma SCL is a benign lipomatous neoplasm. It's actually a benign soft tissue tumor, and it arises from the subcutaneous tissue of the head and neck and upper back. When you look
Head
at it,
and neck.
yeah, head and neck, I think it should not, but I don't think it's restricted to that. Anything can come up from anywhere a lot of times, but mainly head and neck and upper back. So if you see something in the breast with collagen, spindle cells, CD34 positive, we will call it myofibroblastoma. But if you see it in the head and neck region, we likely be calling it spindle cell lipoma. And the question, the thing is even confusing because you expect that in lipoma, you see a lot of fat cells, but here, you don't even see fat cells. Or although they say they have fat cells, let's see. So the according to definition, it's a benign lipomatous neoplasm with varying proportion of mature adipocytes, bland spindle cells that are fibroblast-like, and ropey eosinophilic collagen. This collagen and the spindle cells is what makes it resemble myofibroblastoma. There is a variant of it called pleomorphic lipoma. It's a variant of spindle cell lipoma that pleomorphic multinucleated giant cells with floret-like nuclei. They show degenerative ATPR, but are also benign. In terms of incidence, 1.5% of all adipocytic tumors is spindle cell lipoma. It's common in middle age to older adults. Um, male predominance of 9:1. Male predominance of 9:1. I mean, it's a male tumor, just like okay, it's head and neck anyway, so it's not breast issue. It's found in the shawl region. What do you mean by shawl region?
You use it to cover your neck now. Use it so to cover your head and neck
What
towards
is,
the back.
do you know what, is there anything called shawl?
Is it not what you use in Middle East to cover neck?
I don't know. My wife said
Is that
this.
not what the Arabians use?
What?
The
That,
Arabians.
oh, I don't know clothing, no. Eh? Can you see? You're right, oh. It's what they use in Israel in the days of Jesus Christ to cover. Look at it now. This is shawl. Wow. Wow. Uh-uh. So it's called shawl regions. English is good, though. Anyway, go on the posterior neck, shoulder, back and shoulder. So the shawl region is less common in the face, less common in the parotid gland, oral cavity, larynx. In those areas like face and parotid gland and larynx, it's more common in women. There is symptomatic lesion, very slow growing, just like lipoma, very mobile, it's solitary, long standing. In terms of pathogenesis, it's like you said, it has the same cytogenetics with myofibroblastoma with loss of chromosome 13q, which is 13q14, deletions in chromosome 13q14, which corresponds to loss of retinoblastoma gene. Retinoblastoma, the FOX01 implicated in adipocyte. FOX01 is a gene that's implicated in adipocyte differentiation. So FOX01, sorry, got mutated.
Which picture
Deletions.
is this one?
Huh?
The picture on the left. Which picture is that?
This is a spindle cell lipoma.
Okay, okay.
They also have deletion C16. It doesn't have amplification of oncogenes like MDM2, CDK4, and so that differentiates a liposarcoma. MDM2 is found in bigger liposarcomas and all those things. Those are histopathologic features. Gross. Grossly speaking, is well circumscribed tumor, soft to firm, pale yellow or white. Let's go. Let me go. We can look at this. This is the gross spinal cell proliferation and collagen. They have some myxoid changes and some fatty areas. These myxoid changes in the stroma. Lipocytes are also there, mature lipocytes. These are pseudo-lipoblasts. Lipoblasts are usually, I think, are really smaller, multivacculated. I don't know. This is pleomorphic lipoma with ancient change. What is an ancient change? But what we know about pleomorphic lipoma is that it has multinucleated giant cells. Look at these multinucleated giant cells. If you start seeing multinucleated giant cells, call it pleomorphic lipoma. It's well circumscribed. Myxoid changes can be there. There's
Mm.
collagen and fats in the same tumor. Lipoblast-like cells. It is CD34 positive. So let's continue with this thing. No, sir.
Yeah, me too.
So we can continue from your where you stop. Demographics and lack of etiologic association.
Uh, so myofibroblastoma epidemiology, middle age to elderly. So most common, very common in the best, especially in males. But you could have extra mammary sites, which include inguinal region, pelvic, axilla. There have been no established risk factors or association.
I didn't get that. Okay.
I said there's no association with hormonal therapy, with family
Mm.
history, and the likes. No known association.
Okay, point 4.
Sorry. But it's so we're considering follicular basal tumor and myofibroblastoma. Okay, both are CD4 positivity, both are simple cell morphology, then variable collagen deposit. Um, for solid fibrous tumor, we have STAT6 expression, so that with there's fusion gene NAP2 and STAT6. Then myofibroblastoma lack fusion gene. Then some fibroblastoma may show some pattern, hemangioperitoneal vascular pattern, not seen in myofibroblastoma.
What does that mean?
Eventually, we have like what they call those
Yeah,
stang on shape branching vessel
yeah.
within the architecture.
Mm.
That is not seen in myofibroblastoma.
Mm.
Stang on vessel is not seen, but it can be seen in solid fibrostoma. Then translocation, sorry, yeah, fusion gene, NAP2 and NAP2 STAT6 is seen in solid fibrostoma, not seen in myofibroblastoma.
Mm. Okay. So do you know very well about solitary fibrous tumor SFT?
What is it?
Do you know solitary fibrous tumor very well?
I think I do. I know soluble fibrous tumor.
Yes, very well.
Yeah, I have some knowledge.
Could you quickly review it? Let's quickly review it now. I don't know much about it. And see how
O-
similar it is. We'll not spend much
Okay, okay, okay,
the more we because these are very close mimics. So
okay.
only three. At least now we can I've heard this tumor so many times in my program. It's so they mention it a lot. So and I don't know what it is. I keep saying, you know what, one of these days I will gonna become a senior. Now I'm not a senior.
It's okay.
So let's look at well so far look at this. This is the hemangioperisitoma pattern versus we were talking about earlier. I don't think it has this collagen something that it goes into spindle cells. But let's quickly see. So what's the hallmark of solitary fibrous tumor that differentiates it from myelofibroblastoma?
Uh, Histologically, they have start-gone vessel, the branching vessel.
Mhm.
Then the the translocation NAP2 start
The
6.
fusion gene is NAP2 STAT6 fusion gene, yes. It's pathognomonic. So if anybody mentions solitary fibrous tumor, just say NAP2 STAT6 fusion, and all they think about is SFT. So SFT is NAP2 STAT6 fusion gene is pathognomonic for solitary fibrous tumor. So let's look at it. So look at this. So solitary fibrous tumor is a fibroblastic mesenchymal neoplasm characterized by prominent staghorn branching vascular pattern. This is vascular staghorn vessels, prominent staghorn vascular pattern, patternless architecture and histology. It's patternless architecture and histology. And so in histology, it looks like nodular fasciitis. It's patternless architecture. It's a fibroblastic mesenchymal neoplasm, patternless pattern like nodular fasciitis. Historically, a lot of tumors before that were called a lot of tumors are now called SFT tumors. Initially, there's a tumor called hemangioperisitoma, which has these tagon-like vessels. Now it's called SFT. Giant cell angiofibroma is now called SFT. Localized fibrous mesothelioma is an obsolete term. It affects age range is 20 to 70 years, occasionally occurs in children. Both sexes are affected equally, unlike spindle cell lipoma, which affects males 9:1. Superficial SFT is more common in women, while lipomatous SFT is more common in males. The sites, pleural, thoracic cavity, abdominal cavity, retroperitoneum, extremities, head and neck, orbits and nasal tract, viscera, liver, kidney, prostate. It's in slow growing painless mass. Subcutaneous or deep soft tissue involvement is known. It doesn't cause any paraneoplastic hypoglycemia. Because it causes paraneoplastic hypoglycemia via insulin growth factor 2 secretion. Do you know growth factor 2? Insulin growth
Hmm?
factor. Insulin growth factor behaves like growth hormone, right? Can't remember.
Uh, yeah, yeah.
Growth hormones are counter-regulatory hormones that decrease sugar level. Am I sure? So no, insulin. Insulin like growth factor, yes. Insulin is the one that pushes down sugar. So if you secrete insulin like growth factor, you're going to push down sugar level leading to hypoglycemia. Okay. So pathogenesis is SNAP2 STAT6 fusion and but it doesn't have this 13q deletion now. I don't know why they are worried. So what IHC can you use to to mark as a surrogate marker for the NAP2-STAT6 fusion gene.
Hello?
What IHC can serve as a surrogate marker for the gene fusion NAP2-STAT6?
Okay, surrogate for the IAC for the fusion, right?
Yeah,
What about STAT6?
yeah, STAT6. Other genetic mutations are TET promoter mutations, you know. So this is also CD34 positive, just like myofibroblastoma. 36 is a nucleus thing. Okay, so I think yeah, that's all we need for now. So let's quickly look at this. These are bland fibroblastic cells interspersed with collagen in a patternless pattern. CD34 positive, STAT6 positive, variable cellularity, tumor collagen interspersed, bland cytologic features, vascular hyalinization, 6 hyalinized vessels, focal mark vascularity, lipomatous fat forming SFT, the SFT that has fat, hyalinized lipomatous SFT, myxoid SFT, myxoid SFT, myxoid lipomatous SFT, myxoid SFT vasculature, prominent stroma collagen, keloidal collagen fibers, hyalinized sclerotic SFT, hypocellular SFT, striking collagen production, architectural patterns, cystic change, epithelial morphology, cellular SFT, cellular SFT, multiplicated giant cell SFT, giant cell niche SFT, osteoclast like giant cells is some kind of NFT, embolization material, high risk NFT with mitotic weight, particular growth pattern and necrosis, pleomorphism, pathologic features abnormal, CD34 expression, prominent blood vessels, cellular myxoid areas, smaller nucleoli, hepatomatous SFT, malignant SFT, mast cells in SFT, particular growth pattern in SFT, human collagen in SFT, prominent dilated vasculature in SFT, multiplicated stroma giant cells in SFT, giant cell rich foci, giant cell rich SFT, giant cell angiofibroma morphology, variation in cellularity, stroma collagen, alanine SFT, embolization material, hypocellularity, epithelial and clear cell SFT, multiplicated giant cells, coded groups. Statics in malignant SFT. So SFT can become malignant. Clearly one. Focal nuclear palisading. So many slides. Malignant SFT. Prominent fascicular growth. Nuclear pleomorphism. Okay, that's all. So, sir, tell me, if you get a soft tissue lesion that has spindle cells and collagen, what are all the things that will come to your mind as differential diagnosis outside the breast? No, sir, are you there?
Yeah.
I said, if you
Like
get a
I'm feeling sleepy. I don't know what's happening.
did you hear? I didn't know what?
I said I'm feeling sleepy.
Ah, sorry. Tell me, if you get a soft tissue lesion outside the head and neck, I'm sorry, no, outside the breast, and you have spindle cells and collagen, What are the other things that will come to your mind?
Our first think of spirit cell lipoma,
Okay. What else?
and well, depending on the degree of collagen, I'll be thinking of keloid.
Okay.
Mm,
But killer is very obvious now from the clinical.
okay. Well, this one too,
Solitary fibrous tumor.
solitary fibrous tumor.
Yes.
Okay. You also have collagen.
Yes, we were dozing when I sleeping when I was showing the collagen. Let me show you the collagen again quickly. Sorry. We have so many slides, unfortunately. But let me select slides that will help you. Let's see if we can pick out some slides. You can see it's of interspersed collagen.
Okay.
It's also CD34 positive. This STAT6 nuclear positive. The collagen. So let's come back. So solitary fibrous tumor, what else? You think of myofibroblastoma, right?
Yeah.
So how do you differentiate these three? I said
Especially from which one and which one.
the squamous cell lymphoma, solitary fibrous tumor, myofibroblastoma. How do you differentiate the three?
Okay, with solitary fibrous tumor, you could um what's the hormonal profile?
IHC.
That's hmm?
IHC, right?
Yeah, let me see.
I will use IHC to differentiate them.
Okay. ERPR positivity
In which one?
in ERAR in myofibroblastoma, negative in solitary fibrous tumor. ERA is negative in solitary fibrous tumor.
Okay.
Then that's the one that always comes to my mind.
What of CD34?
CD34 is not positive in both.
It's positive. I'm talking about three of them now. Squamous cell lymphoma, solitary fibrous tumor, and myofibroblastoma. It's positive in three of them, right?
Okay.
So what else do you use to differentiate them? Hmm?
The morphology, but
SFT, what of SFT? How do you differentiate SFT from
okay, now you can use the morphology first. What's the unique thing in morphology? SFT,
mhm. What we see?
NAPTU-STAT6.
Fusion. Yes, that's genetics testing. That's fish testing. So what will you use to differentiate them in how will you use to differentiate them in how will you use to differentiate them in terms of
Histology, abi?
yes. Remember the hemangiopolycytoma-like pattern of the blood vessels. Staghorn blood vessels will find a solitary fibrous tumor.
Okay, that's true.
Squamous cell lymphoma will have some areas that are filled with parts, in the tumor, because it's a lipoma kind of lesion, and more in males, and it will have this shawl-like pattern distribution. Okay, well done. So number five, sir.
Number five, okay.
Mhm.
Challenges in core needle biopsy interpretation. Um, epitel epithelial filling of myofibroblastoma is plump, round to oval cells, eosinophilic cytoplasm, mimicking epithelial malignancy, may have nuclear polymorphism.
Mm.
Invasive, which is a differential for invasive lobular. Single file infiltration in invasive lobular, disc cohesion, bland nuclear features may look similar on limited biopsy material. The immunochemistry profile, cytokinetic is negative in myofibroblast, positive for invasive lobular. CD34 is positive in myofibroblastoma, negative in invasive lobular. Then desmin is positive in myofibroblastoma, negative in invasive lobular. Then ERPR is positive in both of them. Is there a possible in invasive lobular? Wow, that's true. That's true.
Remember that when you biopsy it, those are spindle
But
cells.
AR will be positive in myofibroblastoma, but negative in invasive lobular. Hydrogen receptor.
Tell me what happens in real life when you get this biopsy and you see what looks like invasive lobular carcinoma. What's the first line of action of?
Cytokeratin.
Very good. So if the cell creatinine negative, that's when you start thinking of mesenchymal tumors, right?
Yeah.
If the cell creatinine positive, you don't even worry about all this mesenchymal tumor. Once it's negative, it's that of my it could be myofibroblastoma. So how will you confirm myofibroblastoma?
Mm. LPR CD34.
AR, CD34. You just do a panel, you do Desmin to look for mesenchymal tumors. Desmin is what you use to look for mesenchymal origin. So if it's possible for Desmin, that means it's mesenchymal origin. So we have to be aware of all these sites and the site analysis to prevent misdiagnosis. Misdiagnosis is what every pathologist tries to prevent. Um, let's answer these questions and then look, are you at home?
Yeah, I'm at home actually.
Okay. So will you be able to what are you going to work tomorrow?
Mhm. I'm not going to work tomorrow.
I know they'll finish this thing. So
I actually want us to finish it too. I don't know.
I finish people. So what time do you
A short break. Can we have a short break?
like
Let's look at this.
how many hours break?
Hmm? 45 minutes. Is it much?
Let's make it 1 hour.
Okay, okay.
Let me answer the questions quickly. So that when we come, we start on a fresh ground. We're going to be starting on what tumor is this? It's a nice work when we come back. So myofibroblastoma, which of the following immunohistochemical markers is typically positive in myofibroblastoma?
CD34.
Yeah, this is positive in myofibroblastoma. And it helps to distinguish it from what?
Nodular fasciitis.
Mm,
Mm,
yeah, and fibromatosis too. Yeah,
okay.
and carcinomas, fibromatosis. Now, what is the most common demographic affected by myofibroblastoma?
Elderly males person notosa females.
What tumor is characterized by infiltrative growth pattern that is typically CD34 negative?
Fibromatosis.
Mhm. What cytogenetic abnormality is commonly shared by myofibroblastoma and spindle cell lymphoma?
Loss of 13q14.
Good. Which marker is used to differentiate SFT from myofibroblastoma?
Stasis.
Mhm. Which of the following histologic features is typical of myofibroblastoma?
Spindle cells with collagen, open collagen.
What is the primary diagnostic pitfall of epithelial myelofibroblastoma in core needle biopsy?
It may look invasive.
Like invasive what?
Lobular carcinoma.
What profile best supports myelofibroblastoma? It's a profile.
CD34, plasmid positive, cytokeratin negative.
Yes. Which of the following soft tissue tumors is most closely related histologically to myelofibroblastoma?
Pidal cell lipoma, the same loss of 13q14.
Myelofibroblastoma is yes. What is the main clinical significance of fibromatosis compared to myelofibroblastoma?
Local recurrence
Yes.
due to infiltration codes.
What is the histologic pattern in myelofibroblastoma that can confuse it with invasive carcinoma?
Single cell group pattern,
In making
invasive lobular.
which of the following statements is true regarding hormonal receptor status of myelofibroblastoma? Hormonal receptor.
RPR, positive.
AR positive, AR positive. What best distinguishes solitary fibrous tumor from myelofibroblastoma at molecular level?
Mitostatic gene
Fusion, yes.
fusion.
Which of the following features is not typical of myelofibroblastoma?
Cytokeratin positive.
What feature helps differentiate myelofibroblastoma from fibromatosis and histology immunohistochemistry?
CD34.
Very good. So what time is it in your place now? It's 12:30, right?
22 past 12.
Do you want us to come back by 1:30 or 2 o'clock?
Which one you want?
No, just tell me the one you that will be easier for you.
Okay, maybe 2 o'clock.
2 o'clock, okay, that'll be my 9 p.m. Okay, now
Yeah.
I'll call you then.
Thank you.
Yes, sir.